I'm Raj Kumar, President and Editor-in-Chief of DevX, back with you again for this series of conversations I've been having with leaders during the COVID-19 crisis. It's been a really remarkable series of conversations. I've learned a lot. Hopefully you're all learning a lot. I appreciate all the feedback. Those of you who are joining us live for this discussion, don't hesitate to throw your questions into the chat window. We really want to hear from you. We've got a really special conversation for you today. Prashant Yadav, Dr. Prashant Yadav, who has many titles, which I'll tell you in a second. I like to think of you, Prashant, as kind of Dr. Supply Chain, as a kind of shorthand, because you are my go-to and our go-to at DevX for everything around healthcare supply chains. You, of course, led that portfolio at the Gates Foundation, a senior fellow at Center for Global Development. You teach at INSEAD at Harvard Medical School. You have lots of hats. You work on many commissions and advisory boards, all focused on this issue of healthcare supply chains. And it must be an especially busy moment for you now during the pandemic. Supply chains are, of course, one of the key issues. So we want to get into all this in a wide-ranging discussion. I want to talk about PPE and tests. I want to talk about critical, infrastructure like ventilators and oxygen, and talk about medicines and even where we're headed with vaccines. So lots of questions, I think, for me, but for those of you who are following this, feel free to throw your questions in as well, and we'll try to have a really great discussion. Prashant, thank you for taking some time to do this.
Thank you for having me, Raj. Look forward to it. This is great. I'm glad you guys are thinking about supply chain and highlighting what often has remained to be an issue in the background that we've only started thinking about when there is a crisis. So I'm glad you all are thinking about this and highlighting it to the DevX audience.
So what's at the front of your mind today? Obviously, the pandemic is evolving. It's a different story in different countries. I've listened and read some of what you've been thinking about during the course of this pandemic. Where is your mind today? What are you focused on at this moment?
So I think it's important to think about what we can do to get ready for things that are coming our way to deliver and distribute in the future. So one is potential vaccines. We have, somewhat of a luxury of time of a few months at least to get ready for it, both in terms of manufacturing capacity, but more importantly, distribution, cold chain, IT systems, things that are not new to supply chains and are not something we only need for COVID-19 vaccines, but are areas that we've not finished our agenda. So this is an opportunity for us to speed up and accelerate some of that work.
It reminds me of during testing when all the focus is on the test and then you realize, well, we don't have enough swabs, right? You have to think of the holistic picture when it comes to a supply chain.
Yes, I think that has been a challenge for many governments and policymakers around the world, which is instead of thinking about supply chains from a full system lens, which will look at what all has to be present for the supply chain to deliver health outcomes, because it's not just about delivering one product or a commodity. In the end, what we care about is the supply chain delivering what is needed to improve health outcomes? So examples of that have been very many, and this is something we call as the O-rings problem sometimes, right? Because big efforts such as a spaceship launch can oftentimes get delayed or run into crisis because you forgot to manage the supply chain for a tiny little component, right? So we've talked a lot about whether it's glass vials or rubber stoppers or syringes for vaccines. And the same thing with many COVID-19 medical equipment, where while much of the attention focuses on, do we have enough ventilators? Are we buying them? Are we getting them? But it could be that little power plug. It could be that little uninterrupted power supply. Those little components which may oftentimes not allow the supply chain to act as a means of delivering health, not just for delivering one piece of equipment.
How do you assess how the world has done on this account, right? We're now several months into the pandemic. We've seen, many stories about shortages, and there are obviously big questions about nationalism around domestic manufacturing. How do you assess, you've been in this field for many years, this pandemic hit, you've now had a bit of time to think about it. How have we done as an international system when it comes to healthcare supply chains during the pandemic?
So I think as an international system, we've historically largely focused on running supply chains on behalf of countries, right? Especially countries that depend upon developing assistance for health, so some kind of external financing to run their programs, the assumption has been we'll help them procure, we'll help them design their supply chains better, and those conversations are between agencies in the international architecture. And that's what we've tried to do in terms of our COVID-19 response as well. And while it is commendable that multiple groups have come together and they've created separate initiatives to focus on COVID-19, the reality is that a supply chain depends upon very granular local information. A country, a hospital manager, a clinician who knows what equipment will fit where best, a practicing pharmacist who knows what are the drugs that they really need more and which are the ones that really need less. That information is what can drive a supply chain effort to be successful or not successful. And on that front, I think we are failing because we're not attempting to bring all of that information either collectively into a global effort or making the decision-making shift to levels where those who have that local information can be the ones making decisions. And I think people often will talk about, well, we can bring this together using IT tools and technology. But the reality is some of this information is not very codifiable. And it's just tacit knowledge that sits in the heads of the minds of people. And we should endeavor to translate that tacit knowledge into as much of codified knowledge as possible. But until we're there yet, we have to rely on local information sets.
Well, and that would suggest that we only find out about gaps once they actually exist. That's very hard to predict them in advance. And it sounds like what you're saying is there's nobody sitting at the WHO or other similar global institutions that can kind of look down into a country and say, okay, I see this network of hospitals in this province are going to be running short in 3 months of some critical supply. That just doesn't exist today. Is that the case, or is it country by country? There are some countries where you really do have that kind of visibility at a granular level and others where you don't. How is it today?
So I think global agencies are trying to learn about very specific granular information, but it's not easy to bring that together in a compressed timeline, especially when there are lockdowns in the countries and the ability to actually move or travel to clinics or facilities is weaker. And it highlights the fact that we don't have an infrastructure to bring such information back globally. And that infrastructure still remains to be extremely weak, in my opinion.
Yeah, I guess in many countries, it would be companies that specialize in distribution, right? They're the ones who their business would be to know our hospital supplies running short. They can go back to the major pharmaceutical manufacturers and say, hey, we need this medication. Is that sort of how it's working, almost kind of business as usual, as opposed to a special response given the nature of the pandemic?
Yeah, so I think it's worth thinking about whether the business as usual is actually such a negative thing as it's oftentimes described for the pandemic. So I think one thing that keeps getting talked about a lot is resilience and the fact that we didn't build enough resilience in the supply chains, implying we should buy from multiple sources, we should buy from multiple suppliers, we should have some local manufacturers. All of that is important. But I think the most important part, in my opinion, is the fact that decision-making should be fast and rapid. And supply chains dislike slow decision-making, right? And supply chains are the best friends that supply chains have are fast decision makers. And when we think about government-run supply chains in countries or even in the international architecture, decision-making is not that fast because intrinsically it comes under greater public scrutiny. So if I'm a civil servant running a supply chain for a country, I know that every action that I take is going to have some kind of scrutiny at the end of it. But private enterprises are faster in that sense, right? Their ability to make quick decisions and say, here is where a shortage is appearing, let me quickly find a source of supply. And same thing with not just larger private enterprises, but smaller social entrepreneurs, like new innovative groups that have come up to work on supply chain and logistics problems in many countries. So I'm not saying that the private sector solves this and that's our only way to do fast decision making. But the key thing is that we have to systematically start making supply chain in the government sector to be more agile agile in giving them the tools so that there isn't a trade-off between the fact that you made your decision quickly, therefore you will not pass the test of public scrutiny, but tools which can say you can do both. You can do your decision quickly, and at the same time, it will pass any test of public scrutiny. And we are at a stage in technology today that we have all the right tools in terms of analytics, decision support systems, which can guarantee both of these things together.
Not long ago, there was a big focus on ventilators. That focus seems to have diminished somewhat. What's on your mind when you look at, obviously there's a diversity of situations happening around the world. The virus is marching on in places like Latin America, particularly Brazil, in India. I mean, as you look at the global picture, what's worrying you right now? Are you seeing a place where you think there is an existing gap or an emerging gap that maybe globally we're just not focused enough on?
So, I mean, absolutely, there's need for critical equipment such as ventilators, other forms of oxygen equipment, not necessarily the most sophisticated ventilators. But I think, to me, what is most important is, are we systematically building the supply chain that will help countries have higher testing capacity? And testing capacity is not a short-term need. It has a shelf life, which is much longer than the current pandemic. We need a way to do systematic testing at large scale across many of the countries in Sub-Saharan Africa, Asia, Latin America. And that testing capacity requires a supply chain to deliver lots of things: machines, components, cartridges, swabs. And that effort hasn't necessarily been running at the kind of scale and velocity that we would like to see. What is exciting on that front, though, is that Africa CDC have recently started a new platform which will focus on testing supplies and other things being purchased for all countries in Africa, which will be useful, because then if we are thinking about where can we insert more technical know-how and capacity on how to do it, we at least have a one platform where we can go and say, well, this will at least solve for all countries in Africa. So yeah, so there's some positive trends, but I think the supply chain for testing is one area that I worry a lot about.
Yeah, because testing is something you need to scale up to very large numbers, presuming there's still a very small percentage of people on the planet who have contracted this disease so far. So there's a long way to go yet. You're right. The numbers are going to be quite large. It sounds like the CDC program, your Africa CDC program you're referring to, is like a procurement platform, so that they will organize procurement, and then countries will go to them and say, this is what our needs are. And so they can get better prices and manage the supplies. We've had other similar institutions. The Global Fund does procurement in a similar way for other countries. Are those institutions have they not kicked into gear quickly enough or adapted quickly enough? I mean, why haven't, given all the investment, including from places like where you worked at the Gates Foundation, why haven't we been better prepared for things like testing equipment?
So firstly, I think we have been reasonably prepared. I mean, if we hadn't made the investments that we made in, let's say, testing for HIV, for TB in the past, we would have been nowhere close to having the machines and then only having to worry about, let's get the cartridges and the swabs and the extraction kits, right? We at least have the machines which were put in place for HIV, for TB, for other programs like that. So that effort has helped. Back to, why do we need another platform, given that we have, many existing platforms? So I think it's an interesting, almost a philosophical question to think about. Can you solve purchasing and distribution problems for the world at the global architecture level, or do you require more regional solidarity? Because it's not just about a technical function of bringing together demand into a technical platform. It also depends a lot on solidarity, on trust, on elements which oftentimes, as you start aggregating up and go to a global level, you start compromising on them. So somewhere in the middle is where I think the right level lies, and we've seen that with the PAHO revolving fund in the case of Latin America. This new effort that's coming out in Africa, we've seen it with the Gulf Coordination Council in the Gulf, etc.
Yeah, and trust is in short supply at the global level. There's a move around nationalism to say, hey, let's manufacture in our country and maybe put export controls so critical products don't get exported in case we need them. And I guess, as you say, if you're talking about a regional platform approach, countries need to trust that platform will distribute product in a fair way to those most in need at this moment. And later, if your country's in need, you can rely on that platform. And you're right, trust at the moment is in short supply. What are you seeing on that front in terms of export controls and location of manufacturing, this broad idea of nationalism? How is that playing out right now?
So firstly, I think trust deficit is our biggest problem in supply chain, both during COVID-19 and more generally speaking, right? I mean, if someone was to say, is it about lack of information? Is it about lack of infrastructure? Is it because we don't have trucks? I think those are relatively tangible problems on which we have a handle, we can solve them. This issue of trust deficit amongst supply chain actors, both in the international architecture, in the country, public sector, private sector, those have been our biggest barriers that we have failed to address, and oftentimes we shy away because we think these are massive problems to solve. And what COVID-19 has done is amplified them, right? Because then suddenly everyone thinks about my own constituents, my own population, what is the best way for me to run the supply chain? And one thing you've got to recognize is that supply chains are, by their intrinsic nature, very global. And they're global not just because we wanted to make things in a place where it is cheaper to make or low-cost manufacturing. They are global because core competencies evolve over time. So some regions over time become very good at manufacturing one component part. And that's not because the cost of labor in that region is lower. That's just because over time, public and private investments go into saying, let's focus on this activity. And then the way the global supply chains operate is they say, well, let me buy this swap from Italy, and then this extraction kit from Spain, bring them all together and serve patients around the world. But the moment we start segmenting the supply chain based on national geography, I often say that the Treaty of Westphalia is not something that is binding on the supply chain. So the concept of a nation state isn't what supply chain design should be based on. But as we fall back into that and say a nation state is how we will define the boundary of our supply chain, we are going to face issues where either we need long-term sustained investments to say, countries will become self-reliant. That will mean higher taxpayer dollars going into purchasing at higher prices. But at the same time, we do have to start on a journey of shortening supply chains. And it's less about, we don't want to rely on one region, we don't want to rely on China or India as a production base. It's more about, we need shorter supply chains. If the supply chains are very long, our ability to run them effectively becomes weaker. If they are shorter, and shorter doesn't mean every country for itself, shorter means there has to be at least a regional manufacturer for test supplies and test kits in Africa. Why does all of the supply for testing have to come from Europe, North America, or China? So that's a short supply chain. Similarly, for medicines, or at least some critical medicines, we need to shorten supply chain. So I think we are going to start on that journey. Hopefully, COVID-19 in that sense is an opportunity to do something which we should have done irrespective, but it's highlighted some of these things which sounded very textbook and theoretical when I was to go out and make the case, but now they've become real. So hopefully people will pay more attention to it. And that's where I think our equilibrium will shift a little bit on this.
That description makes sense to me, but what about China specifically? Because my sense, and I don't know the numbers, but my sense is that they have played a real outsized role, that they're an outlier in that map that you describe of competitive advantages in different places and different products being produced in different countries, that there is an outsized amount of influence they have over the global medical supply chain in terms of both manufactured products and the inputs that might go into manufactured products in other countries. Do you think that is a kind of a fundamental weakness of the overall system, and how do you want to see that changed, if at all?
I think so you're right that for especially for things such as pharmaceuticals and active pharmaceutical ingredients, the reliance on China is extremely high globally, not just in developing countries, even for industrialized countries, it's the same. And the reasons for that have been very many. Some are cost related, some are environmental standard related, some are related to what I'm describing as know-how competitiveness, clustering effects. But I think where we may land in the future is people will start creating hubs for pharmaceutical manufacturing, API manufacturing elsewhere in the world. Initially, it will be at a higher cost. But over time, the same benefits, the same path dependency that we've seen build in the clusters in China will start evolving in some other clusters as well. And then if I'm a country and I'm deciding my strategy of where to source critical medical supplies, I will say, let me have some geographical diversity. Let me buy some from China. Let me buy some from this other hub that has emerged in East Africa. And some from Europe, North America, and then I'll balance them in the right way so that I have enough risk aversion built into it. What will be important though is if I'm a small country, I have small volume of a particular product or a medicine that I purchase. For me to split my small market size amongst 3 or 4 suppliers will hurt even more in terms of price. So that's where these regional pooled procurement platforms like what Africa CDC are doing come into play, which is they say if you don't have enough market size to split, if you pool your volume, then we can guarantee you some more supply chain resilience because we will split our volume from different places. So I think what we'll see is not as much reliance on China, but at the same time, I think if someone is imagining that all of our pharmaceutical supplies and API supplies will stop coming from China, I think that's probably not the case as well. We will see an equilibrium, which will be a combination of what I call as proactive capacity and reactive capacity. So if we know something for sure we want in large quantities, 1 billion doses of something, we may still buy that from a Chinese company and then say we'll have some kind of reactive capacity, which could be a shorter supply chain somewhere closer. So that in case the longer supply chain has a disruption, I can revert back to that. That's the equilibrium that I think most countries will fall into, left to themselves. Whether or not the international architecture is gearing up to support such an equilibrium is to be seen. I hope in the development community we do think about this thoughtfully and equip countries to get ready with this instead of saying, here is what the trading links should look like and so on.
Yeah, it's an important point because it's not clear to me there is a vision coming out of the development community of what the future supply chain ought to be. There's certainly a political voice, a very strong one in many countries about the need for domestic manufacturing and resilience. But the vision you're painting is a bit different. And obviously for small countries, that might be small population or just poor countries that have very small market size. Realistically, they're probably not going to become a hub of manufacturing of these components. And so they need those larger platforms. Otherwise, they're going to be out of luck if there's really a global scramble for these kinds of products. Maybe we can just dig into this a little bit around the vaccine question. I had Richard Hatchett on the same kind of conversation a couple weeks ago, who CEO CEPI. Their ambition, they're thinking about 6 billion doses of vaccine. And you just referred earlier to the fact that there is a potential shortage of the glass vials that you would store vaccine in, and maybe many other questions around how would you get 6 billion doses out very quickly. Most of the focus is on the vaccine itself right now. And you said, we have a bit of time. Do you feel like we're behind the curve? I mean, is it likely that the vaccine will actually get developed and approved before we have the global supply chain set up to deliver it?
So I think firstly, I think what you said about the political dimension of the supply chain, I think my big worry, Raj, is that this is in a way the limelight moment of supply chains, right? We've never received as much media attention, but unless we do something right, the limelight moment of supply chain may very well become the darkest hour of supply chain, because politics will drive how we design production distribution networks, and that's not what we've done historically in the past as much. So that's a slightly worrying point. But on vaccines, I think much of the attention is focused on manufacturing. Will we get a vaccine? Will we have enough volume coming out of a production plant? And yes, I think that is an important part, and I've flagged that we need to look at last vials, many other system components thoughtfully. But let's imagine a scenario that we've solved that problem, and like you said, Richard and Seppi and others are working hard on it, so we may have a reasonable amount of capacity. What happens next? Right? Are we truly ready to put a vaccine that requires even simple cold chain? So let's not even talk about something that requires very specialized temperatures, but let's say the 2 to 8 degrees centigrade vaccine. Are we ready to truly roll out 5 to 7 billion doses? Because if we look at the amount of time, effort, and resources that have gone into building the cold chain infrastructure for pediatric vaccines through the efforts of Gavi, UNICEF, the Gates Foundation, many other partners, it has taken us almost a decade and hundreds of millions of dollars to have working fridges, to have the right kind of power systems for them, lots of other things, information technology. And now we are seeing we need to do that at anywhere between 3x to 5x more for 5 billion doses of COVID vaccine. And can we do that in 6 months? Can we do that in 12 months? Are we seeing enough interest and convergence of everyone saying this is our next problem to solve? No, we're not doing that. People are thinking about it, but I think a lot more attention and focus needs to go there.
So cold chain is the thing. When you think about all of the elements, it's cold chain that is kind of the most worrying, because that's not easy and quick to ramp up. And it's particularly a challenge in the lowest resource parts of the world, where we might say the vaccine exists, we built the doses, they're freely available through some global platform, but we just can't actually deliver them. Is that what your kind of call to action to this community is?
Yeah, so cold chain, just because it's easy to supply medicine or vaccine, but to go out and install fridges in remote rural parts of the world, around the world, requires time and to kind of transport logistics capacity, operational capacity, which itself is under constraint due to COVID-19. And the second thing, which is related to cold chain, is the ability to run a mass vaccination campaign. Right? We've done pediatric vaccines for decades now, and we've mastered the art of doing that in some ways as to how many people will come, how we'll predict that. But now we're saying on a given day, we'll have a mass campaign in which hundreds, if not thousands of people will come. How would we manage that? Staff, operational resources, supplies. Unless we start planning for it now and create almost simulation games that people can run the scenarios on, it's unlikely we can do that at the scale that's needed.
Okay, yeah, that's a pretty important call to action, because as you say, most of the focus is really on vaccine development, but that's not the end of the story. We have to think about the whole picture. What about for some of the treatments? We now have a steroid, a pretty common steroid that has been shown, at least in some studies, to be efficacious for hospitalized patients. And we have remdesivir, which is another product that seems to be efficacious. Do you feel like, because those are just for hospitalized patients, the most critical care situations, that the supply chain there is going to be relatively straightforward and robust, or is there anything there that we should be concerned about?
So I think there's a common fallacy that hospitals or larger tertiary care hospitals don't face supply chain challenges, and the supply chain challenges are largely to rural or remote facilities. Oftentimes you'll find that the tertiary care hospital in the capital city of a country is stocked out on lots of items that they're supposed to stock. What will work to our benefit for now is, given the attention COVID-19, I think anyone who purchases and distributes will make sure that if a hospital is treating patients with remdesivir or dexamethasone, they will get there unless there's a global shortage. But will we be able to maintain that over time? Will that short-term attention dissipate over time, and then we will see large-scale stockouts of remdesivir or dexamethasone when we still continue to have severe cases of COVID? I think that's where the challenge will lie.
Makes sense. Can you talk a little about the case of India in particular? We had a question come in about that. I know they are, an interesting country in that India has significant pharmaceutical development and manufacturing capability. They've instituted some export controls early in the pandemic, and now the case count there has been dramatically rising. Any insights you can give us to the situation in India specifically?
Yeah, so I think on one side, you'd assume that at least for pharmaceuticals and also to some degree for medical equipment, India is a large manufacturing base. So in that sense, they should have supplies internally. And the export controls presumably were instituted with that in mind. But in-country supply chains is different than export supply chains, right? So in India, what we see is that things which are exported, the supply chains for managing them are quite well run. But when you think about the same product being distributed to rural parts of India or states or communities which are farther away from the more developed portions, then the supply chain becomes actually quite weak and weaker than in many low-income countries around the world suddenly. So, and couple that with the fact that there were lockdowns and logistics was not allowed to happen in the full form. So suddenly we see things which are to be distributed in India come under constraint. The government is running a system trying to get that out as much as possible. But then once again, I go back to what I'd said about testing, which is one of the big things for India will be how to design a supply chain network that can test billions of people. Not the millions that they are testing now, but billion, and that suddenly means a supply chain network, which will be very different than what the government is currently running probably, and it will also be a test of ingenuity and how to design such systems, right? Because it requires bringing private sector actors together, private labs together, private logistics companies, exchanging information with them, contracting with them on delivery terms, etc. So it can be a true test of state capacity to execute on a supply chain function.
Yeah, there's been a bit of a controversy. I don't know if you followed it. There were just some reporting on it yesterday that the U.S. government through USAID is going to be distributing ventilators and is now sending them all over the world. And the controversy, which has come out about in a letter from Senator Menendez, who chairs who's the ranking member on the Foreign Affairs Committee in the Senate, is basically saying, hey, is this really demand driven? Do countries want these ventilators? And are they set up to do the training and the healthcare workforce to deal with them? I wonder if you have any perspective on this idea of exporting ventilators, donating ventilators right now, and how that system works today.
Yeah, so both whether it's donated ventilators or ventilators that are purchased by countries based on, let's say, global financing. In both cases, I think what becomes important to keep in mind is that a ventilator is not like a malaria medicine that you say it's a standardized product, you donate it, and then the country will just install it. It's not plug and play. It fits into an ecosystem. That ecosystem is something that exists in the hospital in terms of infrastructure. It requires a local champion, because the last thing we want is the key ICU physician in a hospital in Delhi or in Nairobi says, this is not the ventilator I'm used to, this is not what I trained on, but yeah, this is what we got. And as a result, they don't use it, or they don't use it safely, effectively. So I think just the idea of donating ventilators is, it's a tricky area to get into, because unless you can truly understand the local ecosystem, have clear information about what will fit in that, and have a local champion in a hospital, most likely an ICU intensivist who says, yeah, this is the right equipment for us, it's unlikely to function. So my quick reaction is that donating ventilators is fraught with all of these concerns that it will end up being in an equipment graveyard someday, because there will be effective use of it.
We're running out of time, but I want to get a couple more questions in if you've got another minute. Somebody's asking, you made this point about cold chain, and somebody who's following this is saying, hey, what can we actually do on that right now? Given how important that priority is going to be for getting the vaccines out. in many low resource countries. How can we better engage, global leaders, country leaders, the private sector? What should we actually go and do after we listen to this conversation with you?
So firstly, I think the good thing about cold chain is that between Gavi, UNICEF, Gates Foundation, others, we have the know-how of how to build it. Right? So it's not that we have to invent the know-how. We know how to do it. We just have to do it in a compressed timeline and with larger scale resourcing than we may have been able to do it in the past. What can we do? It just is about galvanizing everybody together and saying, let's start on it now. Let's not wait for it. But again, people's time is limited. I mean, we are also working hard to solve current COVID-19 supply issues, right? Everyone's attention is on, are we getting ventilators to people? Are we getting, like you said, remdesivir produced and distributed? So how do we find enough attention, time and resourcing to solve a problem, which is still 12 to 18 months away, but not waste this very precious time? And that just requires, everybody galvanizing action and saying, we want to work with our agency or the global agency that I work most closely with. I'll call the leader of that agency and say, why aren't you acting on it? And that's what my call to action is.
You say 12 to 18 months. I just want to ask you about that because a lot of leaders now are coming out and saying, hey, we're making so much unprecedented progress on vaccines. There's 3 in phase 3 trials right now that maybe we could have something by the end of this year. Are you skeptical about that? And do you really think it is 12 to 18 months from this point?
Yeah, so I mean, my expertise is not in vaccine development timelines, but I think my quick reaction is that even if we do have an efficacious and safe vaccine shorter than 12 months, we don't know if that's what we'll use at the level of 5 to 8 billion doses, right? That might still be a vaccine that we use only for certain targeted. So
like healthcare workers.
Healthcare workers or only elderly or those with comorbidities. So I think we still have 12 to 18 months to build up what we need for the eventual rollout at global scale, which would be 5 to 8 billion doses.
So realistically, are we talking like 2022 before many of the countries of the world, and including maybe very large populous but low resource countries, actually get to some kind of herd immunity through vaccines?
Yeah, I don't know if it's 2021, 2022. I mean, that my guesses on that are as good as yours or other people's. I have no inside specialized knowledge on this, but I think at the scale that I'm talking about, which is for the entire population of the world, I think it's hard to imagine that we'll have it in the next 6 months, right? That much we know. Yeah, we have at least 12 months of time or some period of time like that to go out and start installing those fridges and the other technology we need to have this working.
Well, that is an important call to action and something we will continue to follow up on in our coverage at DevEx. Prashant, thank you for taking this time to have this discussion with us on what I think, as you say, is an important topic that normally doesn't get attention, and it's finally in the limelight. So thank you for helping to cast so much light on it for our community here at DevEx. For all of you who followed this, thank you. We'll look into further questions and comments that you have. Please stay tuned to our COVID-19 coverage that our team at DevEx has been on top of, and stay safe, everyone.
Thanks, Raj. Enjoyed it. Thank you.